You're here because you want to get smart fast about things that actually matter, right?
Hmm.
You want the core knowledge, but maybe without wading through tons of dense
Oh,
text.
totally.
Well, you are absolutely in the right place. Today, we're diving deep into something really fundamental: how our bodies change as we get older.
Yeah,
Think of this as your personal shortcut to understanding the fascinating science of physiological aging.
that's a great way to put it. We've really dug into a chapter all about the physiological changes of aging. We've pulled out what we think are the most crucial insights for you.
Okay.
So we'll be looking at the theories behind why we age, the background stuff,
Right.
then the specific ways our different body systems are affected over time. Also, why older folks might be, well, more vulnerable to certain conditions.
And how those conditions might show up differently. I heard that's a thing.
Exactly. That's
Yeah.
key, how illnesses can present in really unexpected ways. We'll also touch on what are called geriatric syndromes and the challenges that come with managing multiple medications.
Okay.
Our mission here is basically to give you a clear, an illuminating picture of the aging process, but without burying you in jargon or excessive detail.
Perfect. So let's jump right in. Theories of aging. Where do we start with that? Seems like a huge topic.
It is, but the chapter breaks it down into two main camps, essentially. First, you've got the programmed theory.
Programmed, like it's scheduled.
Sort of, yeah. These suggest that aging is, in a way, predetermined, like there's an internal biological clock ticking away.
Mm-hmm.
Examples they give are things like telomere shortening, telomeres.
Remind me.
They're like the little protective caps on the ends of our DNA strands. Think of the plastic tips on shoelaces.
Right. Okay.
They get shorter each time a cell divides, and eventually that signals the cell to stop dividing. And another example is the natural decline in certain hormone levels as we age.
So our bodies kind of have a built-in expiration date, in a sense, or at least a timeline.
That's the core idea, yes. Internal, maybe genetically influenced processes pushing aging along. But then on the flip side, you have the damage or error theories.
Okay, damage error. Sounds more like wear and tear.
Exactly. These theories focus more on the cumulative effects of damage that builds up in our bodies over our lifespan.
From what? Like environmental stuff?
Yeah, things like oxidative stress that's damage from unstable molecules called free radicals,
Mm.
and also just the accumulation of errors or damage to our DNA over time from various sources.
So it's like our bodies are constantly under attack, maybe subtly, and the damage just adds up over decades.
That's a good way to think about it. And honestly, it's probably not one or the other. It's likely a complex interplay between these programmed aspects and the accumulated damage that drives aging.
Right. Makes sense.
And all this leads into a really, really important concept discussed in the material: the loss of physiological reserve.
Physiological reserve. Okay, break that down for us. What does that mean practically?
It's basically our body's built-in cushion. It's the natural capacity we have to cope with stress and bounce back.
Stress, like emotional stress or physical.
More like physiological stress. So
Yeah.
getting sick, having an injury, even major physical exertion. Think of it like a resilience bank account.
Okay, I like that analogy.
When you're young, that account is usually pretty full. You bounce back quickly. As we age, that reserve, that balance, tends to gradually decrease.
So even a minor illness feels like a bigger deal, takes longer to recover.
Precisely. Because that buffer is smaller, even small withdrawals, like a minor infection or a slight injury, can push the body closer to its limits. It makes it harder to maintain that stable internal environment, what scientists call homeostasis.
Right, homeostasis,
Yeah.
keeping everything balanced.
Yeah. It's like your internal thermostat isn't quite as responsive or efficient as it used to be. And this reduced reserve is a big reason why older adults are often more susceptible to illnesses taking hold or becoming serious.
That really clarifies things. Okay, so let's connect that to specific body systems. How does this decreased reserve and just aging in general show up in, say, the heart and blood vessels?
Well, a classic change is that blood vessels tend to lose some of their elasticity. They get a bit stiffer.
Okay.
And that stiffness can directly contribute to an increase in blood pressure hypertension. At the same time, the heart muscle itself might not pump blood quite as forcefully or efficiently with each beat. That's called cardiac output, and it can gradually decline.
So stiffer pipes may be a slightly less powerful pump. Got it.
Ah.
What about breathing our lungs?
Similar theme, actually. The lung tissue itself can lose elasticity, just like the blood vessels.
Huh.
This can make it a bit harder to take deep breaths, and it can also mean the cough reflex isn't as strong.
Oh, that makes clearing things out harder.
Exactly. which can increase the risk of infections like pneumonia. And overall, the efficiency of oxygen exchange in the lungs might decrease a bit.
Okay. And our kidneys, they're crucial filters, right?
Absolutely vital. Kidney function tends to decline with age. Specifically, the rate at which they filter waste from the blood is the glomerular filtration rate, or GFR.
GFR. Okay.
As the GFR goes down, the kidneys become less efficient at removing waste products. This can also make it harder for the body to maintain the right balance of fluids and electrolytes.
Hmm. Let's move to the digestive system. I feel like you hear a lot about digestive changes with age.
Yes, that's common.
Hmm.
Often it's related to a couple of factors. The muscle contractions that move food through the digestive tract can slow down, that's motility,
Slower motility.
right, which can lead to constipation, a very common issue. Also, the production of some digestive enzymes might decrease, which could potentially affect how well nutrients are absorbed from food.
Okay, so slower movement and maybe less efficient breakdown. Now, what about bones and muscles? That seems critical for staying active.
Hugely important. This is a major area of change. We generally see a gradual loss of bone density over time.
Osteoporosis.
It can progress to osteopenia, which is low bone mass, or even osteoporosis, where bones become brittle and fracture risk goes way up, especially from falls.
Right.
And speaking of falls, there's also often a decline in muscle mass and strength. That condition has a name: sarcopenia.
Sarcopenia, muscle loss.
Yes. Plus, joints can become stiffer, maybe due to changes in cartilage. And it's really important to connect the dots here. That combination of weaker bones and reduced muscle mass is a primary driver of the increased fall risk in older adults.
That link is so direct and important. Okay, shifting gears, the brain and nervous system.
Things tend to slow down a bit. The speed at which nerve signals travel can decrease, which might affect reflexes and reaction times.
Okay.
There's also typically a small gradual reduction in overall brain weight or volume, which is considered normal, and many people experience some slowing in memory recall or cognitive processing speed as they get older. Doesn't necessarily mean dementia, just a bit slow.
Right, a natural slowing. And our skin, the outside layer.
Skin tends to get thinner and loses some elasticity, largely due to decreased collagen production.
So, more fragile.
Yeah, potentially more prone to tearing or bruising. And wound healing can also take longer than it used to.
Okay. What about hormones and metabolism? Sounds complex.
It is quite intricate. The production of several key hormones can decrease with age. Think insulin, which regulates blood sugar, or thyroid hormones, which control metabolism.
So that affects energy levels and how we process food?
It definitely can. It can alter the body's overall metabolic rate and how it handles glucose, for instance.
And our immune system, our defense force.
That also changes. There's a term for it.
Immunosenescence.
Immunosenescence. Okay.
It essentially means the immune system becomes, let's say, less robust and maybe a bit slower to respond to new threats. It might not fight off infections as effectively as it once did.
Leading to higher infection risk.
Exactly. Higher susceptibility to infections and sometimes a reduced response to vaccines, too.
Wow. Okay. Lastly, our senses. Vision and hearing seem like common ones. Very common. Presbyopia is the term for age-related farsightedness, difficulty focusing up close. That's due to changes in the eye's lens.
Needing reading glasses.
Pretty much. And then there's presbycusis, age-related hearing loss, especially for higher frequency sounds.
Right.
Taste and smell can also become less acute for some people.
Okay, so putting this all together, all these systemic changes, it logically follows that older adults would be more vulnerable to certain health problems. Did the source material list specific ones?
It did. It pointed out an increased risk for conditions like heart failure, pneumonia, urinary tract infections, often called UTIs.
UTIs, right.
Also, fractures, particularly hip fractures from falls, pressure ulcers or bed sores, and chronic conditions like diabetes mellitus becoming more prevalent or harder to manage.
And it's not just that they get these things more often, but how they get them right. You mentioned atypical clinical presentations. That sounds really important.
It's absolutely critical. This is a major point in geriatrics. The classic signs and symptoms we learn for diseases might be blunted or completely different in an older person.
Can you give an example?
Sure. Take an infection, like a UTI or pneumonia. In a younger person, you'd expect a fever, maybe chills, specific pain. In an older adult, they might not have a fever at all.
No fever.
Sometimes none. Instead, the first and maybe only obvious sign might be sudden confusion or delirium, or maybe just unexplained fatigue or loss of appetite.
Wow, confusion is the main sign of infection. That's, yeah, not what most people think of.
Exactly. Or consider a heart attack myocardial infarction. The textbook symptom is crushing chest pain. Right.
Right.
An older person might not have chest pain. They might present with sudden weakness, maybe confusion again, shortness of breath, or even just nausea.
So much vaguer symptoms.
Much vaguer, much more subtle sometimes. Even pneumonia might just show up as confusion, loss of appetite, maybe a slight cough, but not the high fever and productive cough you might expect.
Recognizing these atypical patterns is vital for timely diagnosis. That's incredibly important for everyone to know, not just doctors. Okay, the information also brought up common geriatric syndromes. What falls under that umbrella?
Right, geriatric syndromes aren't quite diseases in the traditional sense. They're more like common, complex health states in older adults that often result from multiple underlying factors stemming from that decreased physiological reserve we talked about.
Okay, like clusters of problems.
Kind of. They significantly impact quality of life and independence.
Yeah.
The big ones include delirium, that acute confusion we mentioned.
Right.
Then there's dementia, which is the chronic decline in cognitive abilities. Falls and mobility problems are huge. Frailty, that's a state of increased vulnerability, low energy, weakness.
Realty, okay.
Also, incontinence, urinary or fecal. Pressure ulcers. And finally, complications related to polypharmacy.
Polypharmacy. We hear that term a lot. What's the formal definition?
Generally, it's defined as the routine use of 5 or more different medications.
5 or more. Wow.
Yeah. And it's very common because many older adults manage multiple chronic conditions simultaneously. Maybe high blood pressure, diabetes, arthritis, heart disease.
And often see different doctors for each.
Exactly. Multiple prescribers can definitely contribute to the medication count piling up.
And taking that many drugs must carry some risks, I imagine.
Oh, significant risks. The chapter highlighted several. There's a much higher chance of adverse drug reactions, side effects. There's also the risk of drug-drug interactions, where one medication interferes with another.
Makes sense.
It could also be really challenging for the person to simply keep track and take everything correctly. Medication non-adherence becomes a bigger issue. And quite worryingly, polypharmacy itself is a major risk factor for falls.
Wow. The medications themselves can increase fall risk.
Absolutely. Sedation, dizziness, blood pressure changes for meds can all contribute.
That's a lot to manage. Is there a guiding principle doctors use when prescribing for older patients?
Yes, a very important one. Start low, go slow.
Start low, go slow.
Essentially, when introducing a new medication for an older adult, the standard practice is to begin with a lower dose than you might use for a younger person. Then, if you need to increase it, you do so gradually, step by step, while carefully monitoring for effectiveness and any side effects.
That seems like a very sensible approach, given everything we've discussed. Okay, this has been a ton of information. Maybe we should do a quick recap of the highlights.
Good idea. Let's try to crystallize the main points. We talked about the theories of aging broadly, programmed versus damage error.
Right, the biological clock versus wear and tear.
Exactly. Then the absolutely central concept of decreasing physiological reserve, making recovery harder, and increasing vulnerability.
That resilience bank account getting lower.
Perfect. Then we walk through system changes. Cardiovascular, stiffer arteries, maybe higher BP. Respiratory, less lung elasticity, reduced oxygen exchange.
Kidneys, lower filtration rate. GFR, less efficient waste removal.
Yep. GI system, slower motility, risk of constipation, maybe nutrient absorption issues, musculoskeletal bone loss, muscle loss, that sarcopenia, big impact on fall risk.
Neurological, slower reflexes, some memory changes possible, skin thinner, drier, slower healing.
Immune system, that immunosenescence, reduced response, higher infection risk.
And don't forget the atypical disease signs. That was huge. Confusion signaling infection or weakness instead of chest pain for a heart attack.
Crucial point. And the common geriatric syndromes, delirium, dementia, falls, frailty, incontinence.
Finally, polypharmacy, 5 or more meds, increasing risks of side effects, interactions, falls, and that prescribing rule.
Start low, go slow.
Got it. So when you boil it all down, aging isn't just one thing. It's this complex tapestry of interconnected physiological shifts.
Precisely. Changes that influence overall health, disease risk, and even how illnesses actually appear.
And hopefully by understanding these fundamental changes a bit better, you, our listener, feel more equipped with some really valuable knowledge.
That's the goal.
This has been incredibly informative, really eye-opening about the sheer complexity of it all. It makes you think. Reflecting on all this, how might really grasping these basic physiological shifts change the conversations you have, not just about your own future health, but maybe about your parents' or grandparents' health right now? Thinking about those subtle signs, advocating for that start low, go slow approach, it really prompts you to consider how we can all be more proactive, more observant as we and our loved ones navigate the aging process. something to definitely mull over.